Good morning, everyone. We are talking about hemiplegia case. In the first part, I have told how to write the diagnosis and how to identify whether it is due to thrombosis, embolism, or hemorrhage. Now, I am going to talk about how to find the level of lesion and how to find whether anterior circulation is involved or posterior circulation is involved. Because in the diagnosis, you have to write whether it is which artery is involved, whether anterior cerebral artery, middle cerebral artery, or posterior cerebral artery. We have to write in the diagnosis. So in this part, we can see how to arrive at the artery as well as how to find the level of the lesion. Everything you can see. Okay. How to diagnose which artery is involved? So whether anterior cerebral artery or middle cerebral artery or posterior cerebral artery. When diagnosis, we have to write probably due to thrombosis involving the lenticular straight branches of a anterior cerebral artery. We have to write like those. How to find this? So just what do you mean by anterior circulation and what do you mean by posterior circulation? So anterior circulation involves anterior cerebral artery, anterior communicating artery, anterior choroidal artery, middle cerebral artery, internal carotid artery, and common carotid artery. So mainly in this, middle cerebral artery and anterior cerebral artery are branches of internal carotid. So this MCA and ACA involves anterior circulation. So middle cerebral artery and anterior cerebral artery involves anterior circulation. This line in front, all this is an anterior circulation. Posterior circulation are all this. This is posterior cerebral artery, predominantly posterior cerebral artery. This is ICA. This is PICA. This is the common artery, the posterior inferior cerebral artery. This is a common artery involved in the lateral medullary syndrome. That is called the Wallenberg syndrome. So all this posterior cerebral artery and all this basilar artery, everything comes under posterior circulation. The posterior cerebral artery, vertebral artery, and the posterior inferior basilar artery, all comes under posterior vertebral, pica, ICA, posterior cerebral. These are the main important arteries in this basilar artery. All these are important for posterior circulation. Again, this is repeat. So main anterior circulation, internal carotid, anterior cerebral and middle cerebral. These two arteries are very important. So we have to write in the diagnosis AC or MC. In this, we have to write posterior cerebral artery available. So how to differentiate clinically from anterior circulation and posterior circulation? So whenever the patient complains of vertigo, vomiting, giddiness, and uncertainty, ataxia of gait, everything are common only in posterior circulation. It won't be present in anterior circulation. Signs: crossed hemiplegia, for example, that means patient will have cranial nerve palsy on one side and hemiplegia on the opposite side. So this happens only when in the brain stem is involved, when there is an important bonds with brain and medulla. The patient has cranial nerve palsy on one side and weakness on the other side, opposite side. So this type of crossed hemiplegia or element type of patient palsy, like those things if it occurs, you always suspect posterior circulation because all the brain stem are supplied by posterior circulation. So bilateral deficits are also common in posterior circulation. Cerebral sense, ataxia is a feature of posterior circulation. So ocular findings like LMN, facial nerve palsy, IMO, internuclear ophthalmoplegia, gaze deviation to parallel side. This is also most common in posterior circulation because these are all involved this gaze center as well as cranial nerve palsy. So when the lower motor neuron type of cranial palsy is there, you have to suspect posterior circulation. Dissociated sensory loss will be there in plus posterior circulation. And there's a sensory loss over V1, V2, trigeminal area. We have to suspect posterior circulation. Horner syndrome, if it is present, we have to suspect posterior circulation and Wallenberg syndrome. So when all these features, vertigo, ataxia, lower motor neuron type of cranial palsy, and crossed hemiplegia, and ataxia, all this is present, we have to suspect posterior circulation. It won't be present in anterior circulation. Anterior circulation means ACA and middle cerebral artery. So just to go and read this, what are the areas I think you have read in the anatomy, just have a look into this, and so that we can tell which artery is involved. So this diagram shows how where the area, this area is small, is around the lateral, all these are middle cerebral artery. The strip of area on the lateral surface supplied by anterior cerebral artery. So this occipital and the temporal area are supplied by the posterior cerebral artery. So here main is there's a visual area. So here main it's a visual area, so posterior cerebral artery, and this middle cerebral artery supplies motor area, sensory area, and there is speech area over here. So Broca's speech area is there, and also here there's Wernicke's speech area. So all these are involved when the patient have anterior circulation. So ACA, anterior cerebral artery, supplies bladder and leg areas. So predominantly when ACA is involved, leg area is commonly involved, and so patient will have lower limb weakness. You think it up all ALL, just reminder. Anterior ACA means lower limb will be predominantly involved. As well as bladder area will also get involved in ACA. MCA, superior division supplies Broca's area, and inferior division supplies Wernicke's area. So when MCA is involved, speech will be affected. So here patient will have motor aphasia, and here the patient will have sensory aphasia. So motor aphasia, the patient is not able to understand what we are telling, but he is not able to speak. At Wernicke's area, he can speak, but there will be neologism and everything, but he can't understand what we are speaking. So this type of history also you have to ask in the history, whether they are able to understand our speech, or whether they are not able to understand. That you have to ask in the history, so that we can identify whether patient is in Broca's aphasia or sensory aphasia. Posterior cerebral artery supplies predominantly as visual cortex, brainstem, thalamus, and a part of cerebellum. So all the brainstem are supplied by posterior circulation. So visual cortex patient will have homonymous hemianopia or when that's bilateral cortical blindness will be there. So sensory loss, hemisensory loss, like those things is common in thalamic area and cerebellum. So ataxia will be there. So these are the key points in which we can diagnose whether ACA, MCA or PCA. In exam, they used to frequently ask what is the blood supply of the internal. 90% most of the examiners will be asking this question. So just you have to divide in that. This would have read in the anatomy, superior half and inferior half or lower half. So superior half, all these are supplied by the lenticular straight branches of middle cerebral artery. All these are MCA. Inferior half, you have to divide into 3. So inferior half, this anterior limb is supplied by this Pubner's artery, Pubner's recurrent branch of anterior cerebral artery. Then this middle part, genu is supplied by posterior communicating artery. You have to tell posterior communicating artery. This posterior limb of internal capsule is supplied by anterior choroidal artery, as well as the retrolentiform also supplied by anterior choroidal artery. It's just simple upper half by MCA. Lower half 3 divided into 3, anterior limb by anterior cerebral artery, recurrent branch, Pubner's artery. Genu is supplied by PCOM, posterior communicating artery, and Posterior limb is supplied by anterior choroidal artery. So here is anterior cerebral and this is anterior choroidal. In between is generally by opica. So this is common question and a simple question you can just answer. So what will happen when the patient have an anterior cerebral artery occlusion? What will the clinical features will be there? So when right ACA is uploaded, patient will have a left hemiplegia. For example, this is a territory of anterior cerebral artery. So when left side is affected, patient will have right hemiplegia. So patient will have contralateral paralysis of leg and foot with paralysis of arm, cortical sensory loss over leg and foot. So cortical sensation you can check in this area when you are suspecting, and if it is absent, you can suspect anterior cerebral artery. Presence of primitive reflexes, momental reflex, like those in patella reflex, momental reflex. It is an important primitive reflex by which we can diagnose patient is having anterior cerebral artery occlusion. Just a clue, it's not a diagnostic reflex. And urinary incontinence. So bladder area is located in anterior cerebral artery territory. So patient may complain of urinary incontinence. Patient may have gait apraxia, mutism or delay, lack of spontaneity of motor acts, apraxia of left sided limbs. So these are when the patient have left sided looking corpus callosum, when the corpus callosum is involved, apraxia. So, and the point is lower limb weakness will be more than the arm. You can see this is light and this is dark because patient will have more weakness in the lower limb. So the salient feature is patient will anterior cerebral artery, patient will have hemiplegia 1, patient will have urinary incontinence 2, and patient will have lower limb weakness more than lower limb weakness more than upper limb. These 3 points is important in the examination you have to tell, as well as in the history taking or in the examination when you are doing, you should clinically demonstrate that the patient is having predominantly lower limb weakness. For example, if you ask the history, patient may say, I'm not able to move my left to lower limb or right lower limb at all, but he may be able to lift his left upper limb or right upper limb. So when he is able to lift the right upper limb but not able to move or the right lower limb, then you have to suspect it ACA territory first. In the examination also, when you are mentioning the power, you should mention somewhat here, it may be 3/5, 4/5, but here it may be 0/5. So you have to clinically demonstrate, tell also how much is the power. When here power is 0/5 or 1/5, and here when it is 2/5 or 3/5, then you can also suspect the patient is having ACA. Again, reiterating, patient will have hemiplegia, urinary incontinence there, and lower limb weakness will be more than upper limb weakness. These 3 points are very important when you want to diagnose ACA territory. So if ACA is in block distal to the ACOM, there is hemiplegia and hemisensory loss of the opposite side body, where lower limbs are much more involved as crural dominance than upper limbs. If hemiplegia is due to blocked middle cerebral artery, due to middle cerebral artery, the weakness is more marked in upper limbs due to brachial dominance. So MCA, upper limb will be more involved than lower limb, and in anterior cerebral artery involvement, lower limb will be much involved than upper limb. In ACA, face is not frequently involved. I said upper limb will also be light, and so light also face will also be lesser involvement or not involved. Urinary incontinence very common. Presence of mental symptoms. Presence of release reflexes. So these are the features of ACA. Now I have told the middle cerebral artery. So this is the ACA territory. You can see motor area for foot and leg That means lower limb is frequently involved. So patient have predominantly lower limb weakness. Internal carotid infarction. I think internal carotid its branches are MCA and ACA. So whenever patient have a ACA features clinically suggest of ACA as well as features suggest of middle cerebral artery, you have to suspect internal carotid artery. So these are the areas now coming to the middle cerebral artery. So middle cerebral artery supplies motor area, sensory area. You can see this is the Broca's area, motor area, and this is the Wernicke's speech area, and some amount of occipital area also, visual cortex in some amount. So these are the predominant areas that are supplied by middle cerebral artery. So motor area, sensory area, and Broca's area, Wernicke's area, is auditory. This is somewhat occipital. So contrast, this contrast eye center. So these are the areas. So when our middle cerebral artery gets struck already damaged, these all these are get involved. This is superior division and inferior division. So when superior division involved, predominantly patient have weakness as well as Broca's speech area will be involved. This is inferior division. So inferior division doesn't supply to the motor area. Patient may not have weakness, but patient may have only speech difficulty. When speech area will get affected, so sensory aphasia. So patient may not be able to understand what we are speaking, and he may be talking himself irrelevantly with neologisms and everything. So what will happen to the middle cerebral artery? We see the picture here. So upper limb is dark and lower limb is mild dark. So upper limb and face. So upper limb will be more involved than the lower limb. Contralateral, like ACA, the patient like hemiplegia, upper limb more involved than the lower limb. Contralateral hemisensory loss. So hemisensory loss also may be there. So always identify hemisensory loss by pinprick test, doing simultaneously the right side and left side, and ask the patient whether there is any difference in appreciating sensation. Don't just go on whether they are able to feel or the pain alone. Ask whether there is any difference between the right and left side. Contralateral emission, the conjugate gaze paralysis. Patient looks toward the side of the lesion. So when the patient is having left side MCA territory involvement, eyeball will rotate it toward the left side. That's called conjugate gaze paralysis. Broca's dysphasia. If the Broca's problem will be one dominant lobe, it will Broca's area will be present may predominantly in the dominant lobe. Only when the patient having left-sided lesion, patient will have a speech difficulty. This Broca's aphasia or dysphasia will occur. So when you are in the examination, when you are being given a case, and if the patient is having right hemiplegia, always the patient may have, mostly they will have Broca's dysphasia or Wernicke's aphasia. But when you are given in left, mostly aphasia won't be there. It may, but mostly it won't be there, because for most of the patients, dominant lobe is left-sided. Even for the right-handed person, the dominant lobe is left-sided. Even for left-handed patient, 50% will have a dominant lobe on the left side and 50% will be on the right side. So whenever there is a left cerebral artery occlusion, left middle cerebral artery occlusion, and patient having hemiplegia, right hemiplegia, then only you have to tell patient probably having motor aphasia, patient probably having Wernicke's aphasia. So right hemiplegia alone, patient will have motor or sensory aphasia. Just have this point in reminder. So mostly left side hemiplegia patient will talk normally. So middle cerebral artery patient may have due to the just minimal posterior branch, inferior branches get affected middle cerebral artery. It's some strip of cortex of the occipital lobe is also involved, and patient may have contralateral homonymous hemianopia may be there, as well as Wernicke's aphasia, because it affects the, I have told you, the inferior division will affect the Wernicke's area. So on left spatial neglect, right-sided MCA territory occlusion may have left spatial neglect. Just remind. So If there is a both superior division and inferior division is occlusion, patient may have hemiplegia, patient may have hemisensory loss, patient may have contralateral gaze palsy, contralateral hemianopia, both Broca's area as well as Wernicke's area is affected to global dysphagia, anosognosia, and amorphosynthesis on the right side lesion, altered sensorium due to massive infarct, massive both superior division and inferior division and M1 stem occluded. Then the patient may have massive MCA territory infarct, and so patient will have a loss of conscience for everything. And later on, patient may go in for coding. So this is same contralateral hemiparesis, sensory loss, and cortical and motor sensory affective. And it's lenticular straight branch occlusion. Just this is what PG standards. Coming to the posterior cerebral artery. Posterior circulation. Posterior circulation, I told you it's a huge thing. It have posterior cerebral, PCOM, vertebral artery, basilar artery, or PICA, ICA, all this comes under posterior circulation. So this is medulla. So when we posterior circulation, when if it is medulla is affected, so medial medulla also may be affected, so lateral medulla is affected. Those when the lateral medulla is affected, it is called lateral medullary syndrome or Wallenberg syndrome. In lateral medullary syndrome, the patient may have 9th, 10th cranial palsy, cerebral arthritis may be there, Horner syndrome will be there, pain and temperature on the upper half of the face will be involved. This all will be present on the same side. So you have to carefully examine 9th, 10th nerve, and our test is to do this, all these things. You have to find any cerebral arthritis is present on the right side. If it is right hemiplegia, right side, this patient is the right side because this sensor loss will be present on the ipsilateral side. So impaired pain and temperature on the upper of the knee. Contralaterally, you will have a impaired pain and temperature of the body. In Wallenberg syndrome, no, there won't be any weakness. In lateral medullary syndrome or Wallenberg syndrome, patient may not have pyramidal tract involvement and patient may not have hemiplegia or hemiparesis. Medial medullary syndrome, when medial area is involved, patient will have 12th nerve palsy and hemiplegia. So when the patient has 12th nerve palsy, tongue deviated to the same side, right, and 12th nerve palsy is there, and there is a hemiplegia on the opposite. Pyramidal tract will be involved. So the face may not be involved. So hemianesthesia sparing the face and 12th nerve palsy with tongue deviated to the same side, then you have to suspect medial medullary syndrome. This is midbrain. So midbrain will have 3 and 4th cranial nerve, midbrain. Pons will have 5, 6, 7, 8. And medulla will have 9, 10, 11, 12. So this is very important, you have to remember. So whenever there is a 9, 10, 11, 12 lower cranial palsy, you suspect medulla. Whenever the patient is having 5, 6, 7, 8 cranial palsy, you suspect pons. Whenever there is a 3rd nerve and 4th nerve involvement, you have to suspect midbrain. These are the things that will also be useful in localization. So Weber syndrome, the patient has ipsilateral 3rd nerve palsy and contralateral hemiplegia. So for example, the patient, this eyeball is not able to adduct because adduction is by 3rd nerve palsy. Abduction is by 6th nerve palsy. So 3rd nerve palsy with contralateral hemiplegia is suspect Weber syndrome. Just have one point. They'll ask what is Weber syndrome. 3rd nerve palsy with contralateral hemiplegia. You just tell. This is Claude syndrome. The patient has 3rd nerve palsy with contralateral ataxia, cerebellar ataxia. This is Claude syndrome. So thalamus. So when thalamogenically branch of posterior cerebral artery will be supplying the thalamus. What will happen when the thalamic lesion? The patient has contralateral hemiparesis, mild hemiparesis. The patient may have only 4/5 or 5 or 4+/5 involvement. Patient will have very fleeting, you can tell it's a fleeting hemiparesis. Patient won't have a 0/5 hemiplegia. So patient will have a hemiparesis and hemianesthesia will be there. So including the face, the patient has sensory hemianesthesia, and patient may also complain of pain over the hemiparetic area. So whenever a patient complains of pain over the hemiplegic area, you should suspect thalamic lesion. In the history also, we can say whether the patient is having any pain over the hemiplegic area. If it is there, we can say patient probably having thalamic level of lesion. Choreoathetosis may be there, ataxic tremor may be there, and mild hemiparesis. Hemiparesis, pain, and hemianesthesia. These are the coordinate fitting for thalamus. So this is left calcaneal occipital. So this when this is the involved, you can have hemianopia. When the left sided occipital area is involved, the patient will have right hemianopia. When there is bilateral involvement, the patient will have cortical blindness. Bilateral means cortical. Bilateral occipital area is involved, a patient will have cortical blindness. So when the basilar artery only divides into two. So when basilar artery is involved, the patient will have paralysis of all four. The patient will have a weakness of all four limbs, bulbar paralysis, eye movement won't be there, nystagmus will be there, and patient will be deeply comatose. So basilar divided into right both to PCA. If the occlusion is there in the basilar artery, patient will have locked-in syndrome like feature paralysis of all four limbs, and bulbar paralysis and everything, cranial nerve paralysis will be involved. To summarize, so internal carotid artery, so come here, anterior cerebral artery, hemiparesis, weakness predominantly lower limbs, ALL, just remember ALL, anterior lower limb. So here, middle cerebral artery, upper limb hemiparesis, hemianopia, and aphasia. So upper limb, here urinary incontinence. So urinary incontinence in anterior cerebral artery, aphasia in middle cerebral artery. So both sensory and motor weak. When these two are combined, we have to suspect internal carotid artery. So these two are branches of ICA. So when these two are both hemiparesis, aphasia, and hemianopia, urinary incontinence there, then you have to suspect ICA occlusion. Posterior cerebral artery, patient may have hemiparesis or may not have hemiparesis, but patient will have hemianopia is commonly present. Ataxia will be there. Vertigo will be there, vomiting will be there, hiccup is also there. Non patient with hemiplegia with hiccup always suspect posterior circulation. So lower motor neuron type of cranial nerve palsy is there, crossed hemiplegia. That means you're told cranial nerve palsy is on one side and hemiplegia on the opposite side. That is called crossed hemiplegia. So when these type of features are present, you can suspect posterior cerebral artery. So these are the things by which we can diagnose whether the patient is having ACA involvement, middle cerebral artery involvement, or posterior cerebral artery involvement. So whenever that's what in the history I told, you have to tell whether weakness is more marked in the lower limb or upper limb. And also in the examination also you have to tell by the telling the power, whether the power is more affected in the lower limb or upper limb. Hospitals also, you have to tell whether distal weakness is more than proximal. For example, patient may not be able to button the shirts or unbutton the shirt or grasp things, but he may be able to lift the upper limb above the head. This means distal is more involved than the proximal. That also clinical picture you have to tell in the history, because perimeter tract involvement is more involved distally. Finer skilled movements are affected more in corticospinal tract. So by what is the evidence for involvement of corticospinal tract? Distal will be more involved than the proximal. That also you have to tell whether distal is involved more than the proximal and whether upper limb is more involved than the lower limb. These two things is very important in the history taking, and it will give a clue to diagnosis. Now coming to stages of hemiplegia. So I have already discussed in the previous episode. Now stage of hemiplegia is stage of neuronal shock. Never tell a spinal shock. It's not a involvement of spinal. Most of the students will tell spinal shock. So stage of neuronal shock or neural shock, stage of recovery, stage of residual paralysis. So stage of neural shock, patient may be drowsy or in coma or even may be conscious. Patient will have aphasia. Hypotonia will be there. Jugs may be absent. Retention of urine may be there, and there may be spontaneous evacuation of feces. Plantar response may be no response or equivocal. Equivocal means also no response. Patient doesn't have plan reflection or extension. So these things I've already told. I'm again stressing that whenever you given a case within 1 or 2 days and you are finding that the tone is flabby, flaccid, mention as flaccid, hypotonia, no, and also when the reflexes are absent, mention it's as reflexes absent or sluggish. And in the diagnosis stage, say the patient is probably in the stage of neuronal shock. So never you have a mind that always hemiplegia will have a increased reflexes and hypertonia and exam, even though patient is in flaccid weakness, you may tell it's increased and everything. When the examiner finds, he may find it's flaccid and reflex may be absent. That means he may find fault with you that you are not examined properly. So when it is flaccid, tell flaccid. When it's reflexes absent, tell reflexes absent. But in the diagnosis, it add patient is probably in the stage of neuronal shock. Stage of recovery, it usually occurs in the following order. Certain examiner may ask this question: which order they will recur? Face may be recovered earlier. Lower limb, first the extensors. Upper limb, first the flexors. So we used to see in many cases of hemiplegia, mostly they used to walk early rather than using upper limb for any user. So lower limb will recover somewhat better than the upper limb. In the lower limb, extensors first recover, and the upper limb first the flexors recover. So dorsiflexion of foot minimally recovered. Final movements mostly. This final movement, fine what they cannot do, even though maximum recovery only they will be able to do. The last to recover. So stage of residual paralysis, patient relieves with slumber and walks in classical hemiplegic gait, that's circumflexion gait. During recovery of human lesion, reflex recovers first. These things also. So recovery of human lesion, reflexes recovers first. Then comes tone recovers, and lastly only power will recover. The two proximal power recovers earlier than distal power. That means proximal, he may be able to lift the limb, but he may not be able to grasp or everything. So proximal recovers faster than distal. Reflexes first, tone next, and power last. So we have now found how to diagnose whether the patient is having ACA territory or MCA territory or PCA territory first. Then we have seen how to write whether the patient is in which stage. So these 2 points are very important in the diagnosis of hemiplegia. In the next video, we can see how you to find the level of lesion. Thank you.